I'll be discussing toxic maculopathy. Most medications can be safely used with minimal concern about retinal toxicity. However, there are few well-described adverse associations, and toxicity may result from normal administration of the medication, chronic use, overdose, and illegal abuse. I will discuss the clinical features, toxic dose, and tests for early detection. There can be varied presentations depending on the layer of the retina involved. Drugs can cause pigmentary disturbance, crystalline retinopathy, cystoid macular edema, and vascular toxic effects. Those that cause pigmentary disturbance include antimalarials, phenothiazines. Crystalline retinopathy is caused by tamoxifen, canthaxanthin. Cystoid macular edema by epinephrine, latanoprost. Vascular toxicity by aminoglycosides. And photic maculopathy by solar gazing. The commonly used antimalarial agents are chloroquine, hydroxychloroquine, and rarely quinine. The indications for chloroquine and hydroxychloroquine are malaria, rheumatoid arthritis, SLE, and cutaneous lupus. The risk of toxicity is 0.5% if used for less than 5 years and 1% if it's more than 5 years. The factors influencing the risk of maculopathy are duration more than 5 years, a cumulative dose of more than 100 grams of hydroxychloroquine and more than 460 grams of chloroquine. Elderly patients, those with kidney and liver disease, and those with pre-existing macular disease. The screening procedure involves a baseline examination within 1 year of starting treatment and annual screening after 5 years. At the baseline screening, a fundus examination is done to rule out associated retinal pathology, and an automated perimetry of 10-2 is done. If available, one of the following should be done: an SD-OCT, a multifocal ERG, or fundus autofluorescence. Those that are not recommended by the current guidelines put forth by the American Academy include fundus photograph, time domain OCT, fluorescein angiogram, full field ERG, Amsler grid, and color vision. Of course, these are not recommended for screening but can be used as adjunct tests. The fundus findings in chloroquine or hydroxychloroquine toxicity include a normal fundus, subtle pigmentary stippling at the macula which can be mistaken for age-related changes, a full-blown bullseye maculopathy, and in the late stages optic atrophy, vascular narrowing, pigmentary degeneration, just like retinitis pigmentosa. Here the most important thing to remember is that chloroquine toxicity can present with a normal fundus. If you only keep looking for a bullseye, by the time the bullseye develops, it's full-blown toxicity and is not reversible. This is a bullseye maculopathy with central hyperpigmentation surrounded by hypopigmentation. The area of hypopigmentation then increases as the area becomes more atrophic and then involves the center. This is multifocal ERG in a normal patient, and in toxicity with chloroquine or hydroxychloroquine, you find depression of the paracentral waveforms. The HVF 10-2 shows paracentral defects with central sparing. The SD-OCT shows pericentral disruption of the photoreceptor ISOS junction as well as thinning of the pericentral layer, perifoveal area. Here you can see the normal thick perifoveal area, and here you can see atrophy or blunting of the perifoveal area. Autofluorescence shows increased pericentral autofluorescence. Treatment of chloroquine toxicity is cessation of treatment. However, there can be progression despite cessation, and the most important thing to remember that abnormalities with visual field and multifocal ERG can be observed even with normal appearance of the macula. Quinine is used for malaria falciparum, for muscle cramps, and illegally used as an abortifacient and for suicide attempts. We had a 28-year-old female who came with sudden painless loss of vision in both her eyes. She gave a history of fever with chills and was treated as malaria and was given injection quinine. On the third day she woke up with both having lost vision in both eyes. Eyes were PL negative. She had a cherry red spot. The ophthalmologist diagnosed her as having bilateral CRAO, and did paracentesis. Quinine was stopped, and then we saw her after 9 days when the vision had improved from no PL to PL-PR inaccurate. Anterior segment findings showed a round pupil which was fixed and not reacting, and this was the fundus, a pale disc, narrowed vessels, a prominent fovea, and a pale appearing retina. Our differentials were quinine toxicity, and since we could not rule out bilateral central retinal artery occlusion, we did work her up towards that as well. This was the angiogram picture. The ERG showed a negative B wave. OCT showed a flat foveal contour. And we just observed her, and at the end of 1 month she improved to 20/25 N6. But she had only central fields, tubular fields, and the disc became pale with attenuated vessels and RP changes in the retina. So management of quinine toxicity is immediate cessation of the drug. The cumulative toxic dose is more than 4 grams. Phenothiazines that are commonly used are thioresin and chlorpromazine. These are used for schizophrenia and other psychosis. The toxic dose for thioresin is more than 800 grams, and for chlorpromazine is more than 800 milligrams per day, and for chlorpromazine is more than 2,400 milligrams per day. The toxicity of thioresin can be seen even after a few weeks of therapy. It goes through 3 phases: a granular retinopathy, then it becomes nummular, and then RP choriocapillaris atrophy, or presenting like large areas of geographic atrophy. This is a toxic maculopathy from chlorpromazine. These pictures are taken from the Shankar Nethralaya Atlas. It shows flex, RP mottling, and flex in the perifoveal area, and the angiogram shows hyperfluorescence from transmission defects. The management is assess the patients at baseline and every 6 to 12 months, and if there's any sign of toxicity, the medication should be discontinued. Tamoxifen is a non-steroidal anti-estrogen which is used as a treatment for breast cancer. The dose is 10 to 20 milligrams per day, and toxicity is seen in doses as high as 600 to 100 milligrams per day. The incidence of tamoxifen retinopathy is 6% when used at a dose of 20 milligrams per day. It produces white-yellow refractile crystals at the macula. It does not correlate with visual acuity. Visual acuity is well maintained unless there is an associated cystoid macular edema. And treatment of tamoxifen maculopathy is to stop the treatment, and the visual disturbances are reversible with discontinuation of treatment. Canthaxanthin is a carotenoid used to treat dermatological disorders. It's also used as a food coloring agent. It produces yellow crystalline deposits primarily at the macula. Most patients have normal visual acuity and ERG, and treatment is discontinuation of therapy. Talc is an inert filler material used for tablets. It contains magnesium silicate. It's used by drug abusers who crush tablets of cocaine, boil it and inject it into themselves. These particles enter the circulation and embolize at various sites. They are seen as multiple yellow-white glistening particles scattered throughout the posterior pole. It's usually seen after use of about more than 12,000 tablets. Does not produce any symptoms, but is usually associated with concurrent lung involvement. So these patients need pulmonary consultation in addition to drug abuse counseling. Cystoid macular edema can be caused by a few drugs. The most common of them are anti-glaucoma drugs, latanoprost, Lumigan and Travatan. The incidence is about 1 to 2%. It's more common in aphakics and pseudophakics. This is a CME. Solar maculopathy is seen in solar eclipse watchers and sun gazers. It starts as a yellow-white foveolar spot, which is then replaced by a reddish spot. OCT shows a partial thickness macular hole in the outer retina. Toxicity can also be seen by the light of the operating microscope. It's seen as a round or ovoid lesion in the parafoveal area as seen here. Vascular toxicity can be seen by use of antibiotics, especially aminoglycosides, which cause macular infarction. You can see intraretinal hemorrhages, a cherry red spot, and retinal opacification. And angiogram shows absence of filling of the perifoveal network. And so you may have a patient who has recovered from the endophthalmitis, but the vision may be lost due to macular infarction. Interferon also causes macular edema and as well as ischemia. These are cotton wool spots. So in conclusion, all ophthalmologists should be aware of the guidelines of screening for toxicity, do a baseline examination, assess underlying maculopathy, as this can later confuse assessment of toxicity, and patients should be informed of the potential risks, and the physician and ophthalmologist are also at risk medico-legally if appropriate screening is not performed. Thank you.